Welcome to Clinical Care Podcast, our very own first podcast. Just to give you a brief of who we are, Clinical Care Platform is a healthcare edutech company that provides continuous educational opportunities for healthcare workers. We have over 100 online courses. We offer CPD points and membership, and the greatest thing about us is that we submit to the HPSA on behalf of you guys. My name is Lesego. Today we will be discussing HIV management, and we are joined by Dr. Lesego Mawela. He is an HIV clinician. Dr. Mawela, welcome.
Thank you for the invitation, and I'm looking forward to this platform growing and to the engagements.
For someone who doesn't know much about the HIV management, a new healthcare professional fresh from school and only starting with their practicals now, what can you tell them that will make them join CCP and learn more about the HIV management?
I think that HIV is a huge epidemic in the world, and particularly here in the sub-Saharan Africa. And we know that the majority of infections actually happen in South Africa. South Africa carries the highest burden. We have in excess of 7 million people who are living with HIV. We have the biggest ART program, and that means over 5 million people are currently on ARVs. So if you are a health worker, whether young or experienced, working in South Africa, it becomes sort of not acceptable for you to know something about HIV. So I want to encourage all health workers, young and old, to join us in the platform and learn and always be up to date.
I have a few questions regarding the HIV management, which is today's topic, to learn more about it as individuals and as healthcare professionals. Can you provide an overview of the current landscape of HIV management in South Africa? What are our goals and how far are we from reaching them?
Yeah, it's a huge landscape. I think in the first question, I sort of covered already some of the key issues. But just to say that we are seen as a country that sets the trend in terms of how we respond to the disease. And this is because we have the high burden, like I've said, and also we have the highest number of patients, on ART. If you look at the South African program, I believe that it started around 2004 or so, after a lot of advocacy, and this treatment was mainly accessible by a small group of patients who could afford to pay out of pocket, for this important service. Following advocacy, the national, ART program was officially introduced in South Africa. I remember in 2010, that's when we started to have large-scale rollout, of this program, where nurses were now allowed to initiate patients' treatment. We started to optimize and really simplify the drugs or the regimens that we use, and I think around maybe 3 or 4 years ago, we also shifted the program, because previously people used to wait until they are a little bit sick. We needed them to, or maybe to say their immune system to decline, for CD4 counts to drop below 200. And that meant that most people came in sick. Some people we couldn't save, people lost, their loved ones. But 3 or 4 years ago, the country then shifted to say now we implement what we call universal test and treat. And this meant that irrespective of your CD4 count, irrespective of how you present clinically, as soon as you are diagnosed and you test HIV positive in South Africa, you are now eligible to be started on ARVs. So there were no eligibility criteria, from that point in time. And today, really, we celebrate a lot of achievements, one being the introduction of very simplified ART regimens. This means that our patients used to take 16, tablets on a daily basis at some point. Over time, reduced to 8 tablets, 4 tablets, 2 tablets. Today, we talk about 1 tablet taken once a day, So treatment is very simplified. And this combination of drugs, which is a combination of tenofovir, emtricitabine, and dolutegravir, also has fewer side effects, for our patients. We are moving from an era where patients used to experience very bad side effects, some of which even caused morbidity, some of which even caused mortality. If you look at something like lactic acidosis, today's treatment is simple to take. It's once a day. It's more tolerable, fewer side effects. Even operationally, if you look at how we manage our pharmacy supply chain processes, when you have 4 or 5 drugs that you need to keep, in stock for our patients versus now you have only one container with 28 tablets. I mean, that is something that we never thought will happen. And I must say that as well, in terms of the landscape, there's now, long-acting injectable drugs that are coming. There's also, some once-a-month tablets. There's implants. So it means that even this one tablet once a day formulation is no longer going to be the preferred mode of treating our people, but it means that you could actually come every 6 weeks, for example, to come and take your injection like we do for family planning, contraceptions, and so on. So I think it's looking very positive. And also as a country, we have the bigger goals, which are around what we call the 95, 95, 95 in trying to close the tap and end HIV. And we strongly believe that it's possible to do that, but it requires a lot of effort, because the 395s refer to us as health workers working with communities and people living with HIV to ensure that every single person in South Africa knows their HIV status. So we want 95% of the 60 million people in South Africa to know their HIV status, trying to find those who are living with HIV, ensuring that 95% of them are ultimately put on ARVs, which is the second 90. And then once we put people on ARTs, we have a responsibility as health workers to make sure that they are supported, to adhere to their treatment, to ensure that we minimize side effects, that they are kept in care, and we simplify. We no longer allow patients to come every month for their treatment just because it suits us as health workers. But actually, once someone has reached what we call a suppressed viral load, which is then the third 95, ensuring that 95% of people on ARVs are kept on treatment and they are virologically suppressed. Once someone reaches that stage, we don't need to see them. Actually, we can see them once a year currently, but I think in the future, once we have even better drug regimens, we might even say every 2 years, for argument's sake. And I think that is going to really encourage people so that they take their treatment, they don't have to miss work, they don't have to miss school, and ultimately, maybe let me talk about the benefit of achieving this full suppression, because when the viral load is fully suppressed, it means you can't transmit it. Can you imagine how relieved one would be to know that, I have HIV, I take my treatment, I get suppressed. It means I cannot transmit it to my loved ones. I mean, we can't wait to achieve that universal U equals to U.
Beyond treatment, what prevention strategies are currently recommended for individuals at risk of HIV, and how effective are they?
Very interesting that you are saying for individuals at risk. So in today's world, we are able to say South Africa has 60 million people, who are part of the population. But amongst the 60 million people, we are all at risk, right? But there are subpopulations that are significantly at risk. For example, if you look at men sleeping with men, what we call MSMs. If you look at people who use drugs, especially intravenous drugs, if you look at certain populations by virtue of how we treat them as society, you look at issues of sexuality, transgender women. It's not like if you are a transgender woman, you have certain behaviors that put you at risk, but sometimes it's because of the way we react, the way we exclude them from some of the services. These subpopulations find themselves in a position where they become very vulnerable, right? There are populations like sex workers, migrants as well. If you look at it, we are all migrants. We are now shooting here in Gauteng. No one is from Gauteng. We are all from everywhere. But particularly about migration, it's issues around how we treat people who are different or who look different from us, and therefore they have limited access to very basic services. Therefore, they are at a higher risk of getting HIV, and therefore we have to design specific programs to reach them and ensure that they are able to access primary healthcare services, including HIV prevention interventions. When we come to the prevention interventions themselves, we talk about multiple combined, because there is no single best intervention except abstaining, right?
Yes.
I don't know what you think about abstaining, but it's a very difficult goal to achieve, because ultimately we have to populate the world. That means at some point, people are going to participate in unprotected sexual contact. So then how do we make it safer? Number one, we still encourage people to do the ABC, so to be faithful. You know, if then you have one partner, you are reducing your risk of being infected very significantly. The other part then is the C, which is condomize. Condoms actually work close to 99.9%. The problem is they are not available when they are needed sometimes, and sometimes people don't really know how to use them. That's why you get a lot of condom bursts. You know, I don't know if you have seen a condom. I always say it's like a balloon. You can play with it, blow it, and it becomes big and big and big and big. So how does something like that burst? it's probably because maybe it's not being used correctly. You know, people put Vaseline on these things. People put the inside to be outside. So there's a lot of things around that. But we have also started to move towards more biomedical interventions. Like we encourage men to circumcise. If your boyfriend, your husband, your son become circumcised, we reduce their risk of getting HIV by up to 60%. So I encourage us as health workers, doctors, to encourage our clients, but also to be trained on how to do these circumcisions, which is also beneficial to women, because a circumcised man also reduces your risk of getting something like cervical cancer, for example. And I know women will say, but this is for men. It's not for men, because if we keep men negative, then we are likely to keep women negative as well. Today we talk about pre-exposure prophylaxis. So now we use ARVs as prevention. So if you feel like you are at a higher risk, you are a young girl, you know, you are a sex worker, you're a migrant, you know, whoever you are, but you feel that I feel that I'm at a higher risk of getting HIV. You come, we test you, you test negative. We are able to then start you on a combination of 2 ARV drugs in one tablet that you take on a daily basis. It's going to keep you, you know, HIV negative should you come into contact with someone who's got HIV. In that space, there's a lot of innovative products coming in. We now talk about the DAPI ring for women. So it's like, I don't know if you know about there used to be also a contraceptive device, which is a ring you put around the cervix of a lady. So a DAPI ring is a ring like that. You put it, you know, under there, around the cervix, it releases the drug. So you don't have to like take and forget taking your tablets every day. There is also injections that are used, which you can take every 4 to 6 weeks. You know, you get your injection for every 6 weeks. You know that you are protected from HIV. I don't know about vaccines. There's still a lot of work being done in that space, but really we are looking forward to some of those interventions coming through. But like I said, if I was to summarize prevention, abstain, you know, stick with your partner, condomize. You know, if your partner is positive, encourage them to take ARVs, because if they take ARVs, their virus becomes suppressed. They can't transmit it to yourself, you know. And then the whole world of pre-exposure prophylaxis, which I've explained. And lastly, there's also post-exposure prophylaxis, which means you have to take it after you've been exposed. So that's a very empowering tool, especially to young people who sometimes go and have fun and wake up next to this person. You don't know what's their name. You don't know what happened overnight, or maybe the condom burst. They visit us, we test you. If you're negative, we provide you with treatment that you must take for 28 days. And this is a combination of tenofovir and emtricitabine for 28 days. And then you are likely to stay negative like that.
We have challenges in HIV management. What are the primary challenges healthcare providers face in managing HIV, and how can these challenges be mitigated or overcome?
Yeah, I mean, as a health worker, the first challenge I see is that we as health workers, we are the first challenge. We are a challenge to ourselves because HIV is managed by a small group of people, serving in excess of 7 million people, as I've said, of which 5 million are on ARVs. That means there is a bigger group of health workers who lack the knowledge, the understanding, the expertise, or even the interest. So I think the first thing as a health worker is for me to encourage you to really reflect on yourself and your level of knowledge of this disease, and what can you do to develop yourself. If you go to CCP, for example, we have weekly live webinars where we try to encourage health workers and really teach and improve their knowledge and expertise. We also have short courses that are CPD accredited, basic HIV, advanced HIV, and ultimately you can even consider joining us for the diploma coaching session so that you write the college, exam. And I mean, health workers are now becoming more and more unemployed. Having this kind of a credential can enhance your employability as well. So I think that is the biggest challenge. Obviously, the HIV world is a fast-moving environment. There's publications every day. There's new knowledge every day. So sometimes people fail to keep up with the trends, and it can be quite intimidating as a health worker to find that by the time you see a patient living with HIV, the knowledge you have is already outdated. So I think that it's more around getting and more people to become champions and help us really to prevent this disease, to treat more patients. And lastly, it can be very complicated. We must be very, very honest. There are patients who present, and to be honest, as a basic medical officer like myself, who is even a diplomat, I have to consult. So there are specialists, especially infectious disease specialists, who have made themselves available to respond to questions. There's hotlines, there's a national hotline and stuff. And really, maybe they should write to you as the clinical care platform if they want to learn more about the support systems that are available when you have a patient in front of you. And lastly, maybe to say as well, have the most updated guidelines and use them, read them, apply them, and then learn as much as you can.
Thank you so much. And are there any promising therapies or research directions on the horizon that could significantly impact HIV management in the upcoming years?
Yeah, like I said, that's why some of us, we work in the space, because you are kept on your toes. There's always something coming in the horizon. Like I've said, there's better drugs around, what we call treatment optimization, from one tablet once a day, one tablet once a month, one injection once every 6 weeks, one injection every 6 months, one implant every second year. So it's going to be very, 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 very awesome. There's a lot of work being done, I think, in the vaccine space, and I think we should continue crossing our fingers and praying that the vaccine comes through, because it's likely to be a big changer. There are people looking at other treatment modalities in terms of where the drugs are targeting HIV in terms of interrupting its cycle. There's people looking at producing antibodies that can rapidly neutralize the virus. So there is a lot, that is happening. I think the biggest challenge with all this is cost, right? Can South Africa, with 7 million people, afford to give 7 million people these injectables? They are very costly. The second part is the registration in the country. These drugs are generally done outside the country, and studies are done, with other populations, the registration process with SAFRA, if there's no technical support in that space, it becomes very, very, very difficult. Following that, the guidelines must be written. Guidelines require experts to sit, and there must be alignment between the public and the private sector guidelines. Then you have to retrain the health workers. Some of the drugs, by the way, some of the injectables, they require very strict temperature control, for example. So from entry into the country up to the patient, you have to maintain the temperature. What is what we call cold chain. So there's going to be a lot. And if you look at the ARVs now being provided by nurses who are called NIMAT nurses, and now I'm talking injectables, what does that mean? We have to reskill all the professionals on safe, injection on the patient side, but also the handling of sharps and needles. Otherwise, they prick themselves. Now you have more and more problems in that space. So, yeah.
Okay, thank you. This was very informative, and I hope everyone learned as much as I did. We have more series of HIV management courses, the likes of NIMART, of which Dr. Mawela has touched on. Please visit us on our social media platforms. We are on LinkedIn as Clinical Care Platform, Instagram Clinical Care Platform, one word, and Facebook Clinical Care Platform. And we are also on WhatsApp 064 543 3928. And you can send us an email at info@clinicalcareplatform.com. And you can also visit our website at www.clinicalcareplatform.com. Thank you so much.